Good morning. I'm Dr. Linda Kirilenko. I'm a member of the Hand and Upper Extremity Division in Kirilenko Orthopedics, and I'm going to be speaking with you this morning about Dupuytren's contracture, which I'm sure you are all aware is the variety of fibromatosis that is of special significance to hand surgeons. A little bit about the history, originally described in the 1100s, but our understanding was refined by Doctors Klein and Cooper in the late 1700s, who better defined the anatomy of the condition and discussed treatment of closed fasciotomy. A further advance was by Guillaume Dupuytren in 1831, who described fibromatosis, and originally it was only in the palm, or his description was originally only in the palm, and rather than the palm and digits. And his advance in terms of treatment for us was open fasciotomy. Our current understanding of Dupuytren's is that it is a benign fibromatosis involving the palmar and digital fascia. The longitudinal ligaments are the ones that are involved, minimal involvement of the transverse ligaments, except perhaps in the first web space. The classic initial presentation is of a palmar nodule, which can be painful. The disease then progresses from nodule formation to cord formation. The cords can thicken and produce digital contracture. The ring and small finger are the most commonly involved. And there certainly can be disease involving the thumb, index finger, middle finger, and first web. Radial-sided fibromatosis tends to happen frequently in diabetics. The prognosis in terms of outcome depends on the severity of the contracture, the number of contractures, the presence or absence of Dupuytren's diathesis, which was described or defined by Houston and White as having a positive family history, bilateral disease, ectopic disease, including Peyronie's disease and Lederhose disease in the the soles of the feet. Contributing factors have also been speculated to include alcohol abuse. Severe arthritis has a worse prognosis because of joint mobility issues. Rheumatoid arthritis tends to do worse as well, as does previous diagnosis of CRPS, female gender, prior surgery, and severe functional impairment. The following factors are felt to be associated with palmar fibromatosis, but not necessarily causal. These factors are diabetes, alcohol, smoking, and positive HIV status. How do we diagnose it? Well, we diagnose it clinically, but the tabletop test is essentially a patient-friendly method to have your patients perform at home to monitor themselves for progression. It involves telling the patient that they need to every once in a while check and make sure that they can still get their palm and volar aspects of the digits concurrently flat on a firm surface like a table. If this is not possible, they need to schedule a follow-up. In terms of what we do for diagnosis, we measure the contracture, a static static measurement is helpful for cords that involve a single joint. A dynamic measurement, meaning that you measure both with the MP flexed and extended, is good for cords that traverse both MP and PIP joints. It's somewhat analogous to the intrinsic tightness test where if you flex the MP joint, PIP joint extension should be improved. And if you extend the MP joint, the PIP flexion contracture will be worse. Ideally, you would measure both. X-ray is really only of value if you're looking for rheumatoid arthritis or if you're looking for osteoarthritis. If you are concerned about an atypical presentation, an isolated knuckle pad, or an abnormal looking wrist nodule that you suspect may not be Dupuytren's, you can consider getting an MRI to assist. In terms of the pathology, it's felt that you start with a susceptible individual who then sustains a trauma. This produces molecular changes in the cells of the palmar fascia, which subsequently leads to fibroblastic dedifferentiation, formation of myofibroblasts, abnormal collagen turnover, and cords, nodules, and ultimately contracture. There is speculation that that trigger may most commonly be some kind of trauma. Dupuytren himself felt it played a role. A little bit more evidence is manual laborers appear to be more susceptible to progression of disease. And I think for the most part, people agree that it probably is a factor, but not necessarily causal. But we have all seen patients who have had really relatively minor hand surgeries, which is a trauma that has subsequently, sometimes even in a matter of months, developed into significant severe contracture. Epidemiology, it's felt to be, or has always been felt to be, a disease predominantly of Northern Europeans. In Norway, the incidence in males is 9% and in females 3%. The global prevalence follows migration patterns and is estimated to be from 3 to 6%. It's common in Japanese individuals, but it's not uncommon in other Asians. It's very rare in Black individuals. And there is a anywhere from a 2 to 1 to 10 to 1 male to female preponderance. Most commonly, it is felt to be the most common inherited connective tissue disease with an autosomal dominant gene with variable penetrance. It's very important to understand the anatomy to adequately understand and treat Dupuytren's, especially if you're contemplating open procedures. Normally, the palmar skin is firmly attached to the superficial fibrous tissues. This allows the skin or the palm to perform its functional demands adequately. The palmar fascia is a continuous digital sheet that extends from the palm through the palmodigital area and into the digits. Normal palmar fascial anatomy includes a description of fascia, ligaments, and bands. Zones of the palmar fascia is palmar, palmodigital, and digital. The palmar fascia, in terms of superficial to deep, has pretendinous bands, which are the most superficial layer, and has connections to the skin called Grapau's fibers. Then there is the vertical septa, which extend from the pretendinous band level deep to attach to the volar plate, deep intermetacarpal ligament, A1 pulley, sagittal bands, as well as the septa of Luciu and Javara, which you may recall are those fibrous vertical bands that separate the metacarpal heads from the canals which contain the neurovascular bundles and lumbricals. The transverse ligaments, at least in the palm, are not felt to play a significant role. These fibers are called Skoog's fibers, or the transverse ligaments of the palmar aponeurosis. The digital fascia, again, we're kind of skipping from palm to fingers, includes the lateral digital sheet, Cleland's ligaments, which are dorsal to the neurovascular bundle and not involved in the disease, Grayson's ligament, which is volar to the neurovascular bundle and is involved in the disease, as well as the dorsal and volar fibrofatty tissue, which has scant connective collagen fibers, but can be involved in the disease. Now, probably the most difficult to understand and anatomically the most complex is the palmodigital fascia, which includes the spiral band, which traverses from the pretendinous band to the lateral digital sheet and Grayson's ligament, the natatory band, which is in the web space, and the vertical septa of Luciu and Javara. McFarlane really advanced our understanding in explaining how there was a direct and predictable correlation from normal anatomy to the development of pathology in this disease. The normal bands, ligaments, and fascia, when they become involved in Dupuytren's, form nodules, cords, and pits. The cords are the central component or the most important component in the pathology, and this is what produces the majority of the contracture deformity. The various cords include pretendinous, the central cord, which is the middle portion of the pretendinous band, the spiral cord, the natatory cord, the abductor digiti minimi cord, the lateral cord, and the radial or commissural, the radial cord to the thumb, which is really the thumb version of the pretendinous band, and then the proximal and distal commissural cords. There's also a retrovascular cord in the digit. The pathoanatomy, again, just a reminder, you go from the normal understanding of the normal anatomy. The pretendinous bands exist in 3 layers. The superficial goes to the skin via Grappau's fibers. When these become abnormal, they produce dermal thickening and pits. The middle portion of the pretendinous bed forms the central cord, which is the bulk of the pretendinous fibers. And the central cord often causes both MP and PIP joint contracture. And then there is the deep band, which contributes to the vertical cord that we talked about a couple of minutes ago with those 5 deep insertions. The spiral cord is contributed to by the spiral bands, the pretendinous bands, the vertical bands of Luciu and Javara, Grayson's ligament, the lateral digital sheet. The only portion of the palmodigital fascia which does not become involved in the pathoanatomy of the spiral cord is the natatory ligament. The spiral cord splits distal to the proximal interphalangeal joint into dorsal and volar components, volarly inserting into the base of the middle phalanx and the flexor tendon sheath, and dorsally inserting into Grayson's ligament and Grayson's ligament and the lateral digital sheath. The spiral cord is a frequently tested entity, and it has special significance because it can displace the neurovascular bundle proximally, centrally, and superficially, making it particularly prone to injury in treatment of Dupuytren's pathology in the pulmonodigital area. The natatory cord produces web space contracture. The radial thumb cord, again, is the pretendinous cord equivalent to the thumb, and the commissural cords have two elements: the proximal and distal commissural cords. The proximal commissural cord is formed by Skoog's fibers or the transverse ligament of the palmar aponeurosis when they become pathologic. The natatory fibers form the distal commissural cord in the first web, and the importance in dissection of the commissural cord in the first web is the at-risk nature of the thumb, radial, and ulnar digital nerves, and the index finger radial digital nerve. The retrovascular cord originates in the finger itself. It's dorsal to the neurovascular bundle, distinguished from Cleland's ligaments. When isolated, it doesn't cause a PIP contracture, but it may cause a DIP contracture. However, when it's present in combination with a lateral cord, you can get contractures of both DIP and PIP joints. The abductor digiti minimi cord is of special interest in that it arises at the musculotendinous junction of the abductor digiti minimi. It's felt that approximately 25% of small finger contractures have this cord. And as the spiral bands can displace the neurovascular bundles in the small finger, the abductor digiti minimi cord moves the ulnar digital nerve proximal and radial, the radial digital nerve proximal and ulnar. And the sensory ulnar nerve can also be at risk during dissection. The lateral cord is the coalescence of the lateral digital sheet, natatory ligament, and spiral band. It occurs in the fingers except the small finger, and it usually doesn't cause a PIP contracture. Most of these fibers insert on the skin. In the small finger, the normal ulnar digital fascia is not the same as in the other digits. And in the abductor digiti minimi, or in the small finger, the abductor digiti minimi cord can act as a lateral cord, but it can also act as a spiral cord. In the small finger, the lateral cord inserts, or the abductor digiti, the lateral cord inserts into the volar aspect of the middle phalanx and Grayson's ligament, producing a PIP joint contracture. And as it travels distally, can also cause a DIP joint contracture. Neurovascular bundle is rare in the index, middle, and ring fingers, but is not uncommon in the small finger. Special considerations to always keep in mind when you're operating or dealing with a small finger involved with Dupuytren's. Again, we just discussed the presence of the abductor digiti minimi cord. It's felt that you can estimate the presence or predict the likelihood of the presence of a spiral band based on how contracted the PIP joint is in the small finger. And there is no natatory ligament in the small finger on the ulnar aspect. Cord combinations have been described. There's the Y cord, which starts separate and may become continuous. The central plus natatory cord can produce MP joint contracture in an adjoining digit. And the central and lateral combination can produce both MP and PIP joint contracture with central neurovascular band displacement. Treatment, our understanding remains incomplete. 4 decades of intense research and investigation have not answered all of the questions. The treatment can be more or less separated into 4 basic groups: open fasciectomy, open fasciotomy, closed percutaneous fasciotomy, and enzymatic fasciotomy. Things to consider when you're determining a treatment plan is the goal of any kind of Dupuytren's intervention is not to eliminate the pathologic fascia, but rather to release that portion of the diseased tissue, producing contracture and thereby improving function. The amount of correction is predictable. However, how long it'll last, meaning what the likelihood of recurrence in, is not predictable as readily. I think the general indications have been classically defined as an MP contraction greater than 30 degrees, a PIP joint contraction greater than 20 degrees, or progressive, web contracture that impairs functionality of the thumb in pinch or grasp. It's felt that it's optimal to wait until the criteria are met, but the PIP criteria are not rigid. And keep in mind that a delay may produce a surgery that may result in a surgery that's more complex and an outcome that's less predictable. You have to keep in mind that when you tackle this, you need to keep all of the components of the disease process, including skin, fascia, and contracture, front and foremost in coming up with a successful treatment plan recommendation. Skin is first to be considered. Multiple incisions are described. It's important to adhere to basic principles, specifically not crossing the longitudinal or the skin creases longitudinally to avoid potential development of a skin contracture. And understand that the incision that you initially may envision and the incision that is made at the beginning of the procedure is often different in appearance in the incision that's present at the end of the procedure. Keep in mind you need to avoid thin flaps to avoid impairing vascularity. Avoid leaving diseased tissue on the skin, as this will increase the risk of recurrence. If the disease is intimately opposed to the skin, it increases chance of recurrence, and therefore you would want to consider as an option excising the diseased skin and fibrotic tissue and using a skin graft. You always start with making the incision proximal. That allows you to release the pretendinous cord and get some extension of the digit. This way, as you proceed distally in your dissection, you can plan your incisions better. Skin nodules, recommendations are to observe them. They can be tender, and there is a role for injection of triamcinolone to manage the symptomatic painful nodules. Estimates, some studies have shown 90% regression of the nodule, or at least significant improvement in the nodule at 3 months. However, 50% of those that do improve recur, and it's unclear whether the injections impact contracture progression. Indications for excision: if you have a nodule that is above the flexor tendon sheath that's involved with triggering of the digit, it's recommended to move the visibly pathologic tissue at the time of release. Any interventions, even a trigger digit release in the face of localized Dupuytrens can result in significant progression of the disease postoperatively. If you have a patient that has severe pain, especially at night, and especially if they're young, you might want to think about doing an excisional biopsy, because fibrosarcoma remains in the differential diagnosis. Ectopic knuckle pads, again, recommendations are to observe. Occasionally, an isolated pad can be the presentation of palmar fibromatosis, if necessary, and there is no palmar disease, but you strongly suspect that this is the first sign of the disease, you can do a biopsy, excisional biopsy, for pathologic evaluation. You should also consider excision if it's persistently painful, especially if it's large. And you can also consider removing it if it interferes with the ability to wear a ring. If you do choose to remove a knuckle pad, keep in mind that just like everything else we take out with Dupuytren's, the disease can recur. And when you're dissecting, it's recommended to dissect proximal to distal, so that you are starting your dissection where there is a tissue plane that will separate the skin from the extensor tendon to the PIP joint, or the extensor mechanism of the PIP joint. So you avoid, or it makes it less likely that you will injure the extensor tendon, producing an iatrogenic boutonniere deformity. Management of the fascia moving off from the skin includes fasciactomy. It can be open limited, which is currently the most common open procedure we perform for Dupuytren's. The goal is to remove the bulk of the longitudinal pathologic tissue, improving the contracture, leaving the uninvolved fascia in place. Excise the transverse fibers for exposure as needed. As you recall, they're not involved in the pathologic process. And again, you start with release of the cord proximally at the approximate level of the superficial palmar arch, followed by digital extension and further determination of appropriate location of incisions. Radical open fasciectomy is predominantly of historic interest. Here, the goal is to remove all fascia, diseased and normal, and it used to be felt that this would decrease the chance of recurrence. However, what has been borne out is that that's not true, that there is a much higher morbidity with this procedure, obviously, because the dissection is so much more extensive, and there is no significant reduction in the recurrence. Open fasciectomy was described by McCash, most often considered in elderly people or individuals with questionable skin. What you do here is you just make large transverse incisions, and when you extend the digit, there's actually a substantial open wound created. You don't make any attempt to close these. You treat them by secondary intention with daily soaks, range of motion, and therapy. And for the most part, these heal over 6 to 8 weeks. Dermatofasciectomy, described by Houston and McGrowther, the skin and diseased tissue producing the contracture rather than the entire palmar skin, and normal and abnormal tissue, which was in previously described. Here, you just remove the skin and fascia that's producing the contracture, and it's felt, or it was postulated, that doing this created a fire break and interrupted the continuity of the diseased fascia, decreasing the chance of recurrence. It's most applicable in young patients with Dupuytren's diathesis, very poorly tolerated in the elderly because of the period of immobilization necessary for graft take. A hybrid or combination procedure was that described by Mormon. This was a limited segmental fasciectomy, which is really a hybrid between the open fasciotomy and segmental fasciectomy. It's a less extensive exposure. You remove segments of the diseased fascia through multiple curved and transverse incisions, and you remove the diseased portion of the longitudinal fibers that are producing the contracture. Fasciotomy, moving on from fasciectomy to fasciotomy. Percutaneous closed needle fasciotomy is a possibility, as is enzymatic fasciotomy. The goal is to release the long cord producing the contracture. The diseased tissue is not excised, and surprisingly, this can often produce significant improvement with a manipulation, passive range of motion maneuver. The technique of percutaneous fasciotomy, you use a 25 gauge syringe, 25 gauge needle on a empty syringe. You use blind multiple needle insertions at multiple levels throughout the cord, followed by passive extension of the digit. This is not done in the palmar-digital area since the increased risk of injury to the neurovascular bundles. The advantage is you can get back to full use of the hand in as little as a week. The disadvantage is there's an increased rate of tendon and neurovascular bundle injuries and less correction. The open fasciectomy is felt to produce about an 80% correction of the original extension deficit, whereas the percutaneous procedure restores about 63%. There's felt to be about a 58% recurrence at 3 years. Most common treatments today can be narrowed down to open limited fasciectomy and enzymatic fasciotomy. Highlights of open limited fasciectomy include proximal release of the pretendinous cord, allowing digital extension and planning and performance of distal incisions. Remove the transverse fibers only as needed for exposure. Address the presence of any vertical cords. As you extend the incision into the palmar-digital area, use Brunner incisions. Keep the flaps thick. And as you're planning your incisions, keep in mind how you're going to close them. Often Z-plasties or VY advancement is used. You extend distally into the digit only after you've exposed the neurovascular bundle. You address each cord as it's encountered, including spiral, central, natatory, lateral, retrovascular, radial, commissural, or ADM. It's recommended to accept up to a PIP flexion contracture of 30 degrees or less, which can be managed with dynamic PIP joint extension splinting postoperatively. If the residual contracture is felt to be more than 30 degrees, you can consider a release of the PIP joint, including the volar plate, in performance of surgery on two adjoining digits, specifically ring and small. Usually this involves a single incision, which over the palm, which is then converted into a distally based web flap for distal dissection to address the palmar and palmar-digital disease. Results of open surgery: McFarland reviewed 1,202 patients, found that 56 of them were improved, 19% were felt to be perfect, but 25% were felt to be the same or worse. Fasciactomy complications: overall 17% complication rate, most of which are minor. Some of the more significant complications: failure to achieve adequate correction, stiffness, loss of digital flexion, nerve injury, arterial injury, flap necrosis. Sometimes salvage procedure of amputation is required, especially in cases of recurrent disease and in cases that involve the small finger severe contracture of the PIP joint. Tendon injuries can happen, as can hematomas, infection, and the development of CRPS. Post-op rehab: in the operating room, put on a soft, bulky dressing, splint the fingers and extension, ice and elevate for 24 hours, keep the hand elevated until maintaining the dependent position no longer produces throbbing. Change the dressing in 2 to 5 days, in 1 to 2 days if you've used a drain. Start OT early for range of motion. Have the therapist make an orthoplast splint early and have the patient wear it at night for 3 to 4 months. Again, residual PIP extension deficit can be managed with splinting. Sutures should be removed in 10 to 14 days, followed by scar massage, desensitization, and a home exercise program. Something to keep in mind: paresthesias are virtually always present due to neuropraxia, due to traction on neurovascular bundles during the procedure. You can differentiate this from nerve transection, because in neuropraxia, the paresthesias almost always maintain protective sensation. Enzymatic fasciotomy. Xiaoflex was approved in 2010. It is a soup of multiple collagenases from Clostridium histolyticum. These collagenases do not demonstrate cross-reactivity or immunogenicity. The different collagenases act synergistically. They unwind collagen helixes and cleaves the bonds, and it predominantly affects collagens types 1 and 3, avoiding the type 4, which is present in arterial and nerve structures. You inject it into the cord, which is producing the contracture, allowing enzymatic degradation, and this is followed in 24 to 48 hours by passive manipulation and production of cord rupture. Indications: same as for fasciectomy for the most part. Initial studies on Xiaoflex demonstrated safety and efficacy. The initial studies that evaluated collagenase were the CORD 1 and 2 studies, which stand for collagenase option for reduction of Dupuytrens. The endpoint for success was 0 to 5 degree residual contracture, with starting greater than 20 degrees contracture at the MP or PIP joint, after up to 3 injections at 30-day intervals. In the Cord 1 study, 64% achieved that goal, and in the Cord 2 study, 44% achieved that goal. Complications: arthralgia, lymphedema, tendon rupture, most frequently occurring in the small finger PIP joint. Contracture management, modifications of technique to avoid tendon rupture involves avoid proximity to the PIP crease, avoid injection below the cord, don't go any more than 2 to 3 millimeters into the cord to prevent deep injection. And you can consider injection horizontally to avoid this as well. Complications identified since the original cord studies: pain, bruising, and skin tears. Allergic reactions are common, but they're usually minor, like itching or pruritus. Very severe allergic reactions are very rare and usually occurs in patients who've had prior exposure or injections. Tendon rupture is a bad complication. This is pulley rupture, CRPS, DVT, and tendonitis. Xiaoflex preparation needs to be meticulous. You use the vial with dry Xiaoflex powder measuring 0.58 milligrams. It's then diluted with a diluent containing calcium. You add the diluent to the powder, you swirl it rather than shake it, so you prevent denaturization. Once it's prepared, it can be kept in the refrigerator for up to 4 hours. It should be removed to room temperature 15 to 16 minutes before injection, but you can't leave it out at room temperature more than an hour. It's recommended 1 vial for 1 needle for 1 injection. The MP joint uses 0.39 milliliters of diluent into the vial, and you inject 0.25 milliliters, and the PIP joint uses 0.31 diluent milliliter, 3.31 milliliters of diluent, and the injection volume is 0.20. Technique: 27 gauge needle on a hubless insulin syringe, chloroprep, no local anesthesia to prevent distortion of local anatomy, inject appropriate volume. Again, reconstitute around the time of the injection. It's got to be used within 4 hours of preparation, as long as it's kept in a refrigerator. More than 1 injection site, start medial and go to lateral. Inject the MP joint first, and then the PIP joint. Inject where the skin is least adherent to minimize chance of severe skin tear. Inject at the area of bowstringing or maximum distance between the tendon and the cord to prevent or to decrease possibility of tendon rupture. In the small finger, don't go any more than 4 millimeters distal to the MP crease. Inject by 1/3 volumes into 3 places in the cord. You can either remove the cord, you can either remove the needle or leave it underneath the skin and just reposition. Apply a bulky dressing. Tell the patient they need to rest and keep it elevated. Come back in 1 to 3 days, at which time chloroprep is then used, followed by local anesthetic, infiltration with lidocaine, placement of a soft dressing so you're prepared when the skin tears, manipulate the digit into extension, keep the wrist flexed for MP extension, and keep the MP joint flexed for PIP extension. The extension procedure itself should be moderate force and static for up to 10 to 20 seconds. You can repeat this up to 3 times with a break of 5 to 10 minutes between attempts. The goal is to have an audible, palpable, visible cord rupture. Ask the patient post-procedure to range the digit, so you can confirm that the tendon is intact. If there's no rupture, you can repeat the procedure at 30 days, up to twice. Oftentimes, the cord will rupture between visits. If you do get a rupture, have OT make them a night splint. Xiaoflex complications, skin tears most common, more likely than not, or not at all unlikely, let's put it that way. Local reactions of local sensitivity and pain, anaphylaxis, again, very, very rare, and usually the patient has had previous exposure. Tendon ruptures felt to be about 0.3%. Recurrence rates is 10% at the MP at 5 years and 20% at the PIP at 5 years. Finally, it's very important to manage patient expectations, tell the patient what the disease is, how to monitor it, and what the treatment indications are. Explain that surgery is designed to improve function, but not cure the disease or even eradicate the disease. MP contracture almost always corrects quite nicely. PIP contracture is less reliable and much more often is affected by recurrence. Overall, recurrence rate estimated from somewhere between 20 to 80%. If you define recurrence as extension or recurrent disease in the same location. And McGrather kind of negatively postulated that if you follow them long enough, 100% of them will recur. However, the good news is even in recurrent disease, repeat surgery is often not necessary. Things for the patient to keep in mind in recurrent disease, it's that it happens more commonly if you're young and male. You can expect long-term functional impairment. If you do get recurrent disease, surgery the second time around will obviously be more complex. Recovery will be harder. OT will be longer. Risks of neurovascular injury and skin complications go up, and salvage procedures, including amputation, PIP fusion, or arthroplasty, are much more common in recurrent disease. Things the surgeon should keep in mind with recurrent disease. You always need to be very careful what the status of the neurovascular bundles are before your redo surgery, since it's not unheard of that the neurovascular bundles will have been injured during the prior surgery and not necessarily diagnosed. So you want to make sure you do a pre-op thorough sensory exam and digital Allen's test to assess for digital and arterial integrity. Do a thorough discussion with the patient and document that discussion clearly in the medical record, including risks, benefits, and potential complications. And before you recommend treatment of Dupuytren's, just like before we recommend treatment of any orthopedic condition, take into consideration patient's activity level, functional demands, comorbidities, expectations, and the need and type of anesthetic. Thank you very much for your attention, and hope you learned something, and have a good day.